How many are doing primary sphincter repair? How many are not doing primary sphincter repair? So those who are not doing it, I would wish that you would start doing it. It's a very simple procedure. We surgeons do everything and we know how to do everything. So please start doing it. So the problem is, anal fistulas are a huge challenge for the surgeons. High incidence, high recurrence rate, prolonged healing time, and fecal incontinence, what we dread. And patients with fistula have a low quality of life because of constant anal pain and soiling from anal tracts. Now, complex anal fistula poses a challenge because of high recurrence rate, post-op fecal incontinence. But the biggest problem is there is no standardization of procedure or treatment choice. You have a complex fistula, you have to really think about it, what armamentarium you have, and what you can do about it. The aim, what do you want to do? Appropriate surgical approach for high healing rate, low post-op pain, low risk of incontinence, low recurrence rate, increased post-operative patient's quality of life. Don't we all want this? Yes, we do. So fistulectomy with primary sphincter repair has stood the test of time over ages. First, you have to know the anal anatomy for high healing rate. That is, you need to know the entire course of the tract. You need to know where the internal opening is and or where about it is in the intersphincteric space. And you need to know about the primary and the secondary tracts. You can't leave them behind. So MRI and the other modalities available, I think, is the best. And as you can see in this picture, it shows very nicely a horseshoe abscess fistula. So classification, like multiple classification, the simplest one we always remember and do is Parkes classification. Then you have the American one divided into simple and complex. And the radiologist, when they give you MRI, it's St. James. So the one in green are the simple fistulas and you're going to operate them without much concern. But the other ones, if you're not good at it or you're not sure about it, it's best not to do it because the patient's life is in misery. Now you need to know about the anal musculature. It's tube in tube. So you have the mucosa first, mucosa, submucosa, then you have the internal sphincter, you have the intersphincteric space, you have the external sphincter, and you have the extrasphincteric space. It's all tubes. And there's no partition in the tube. So if there's an abscess, it can go in the intersphincteric space and go across to the other side like a horseshoe abscess. Similarly, for extrasphincteric space, and then not to forget the suprasphincteric space where the abscess goes around, even the fistula goes around. So when the abscess goes around, the fistula naturally will also go around. So what are the risk factors of incontinence? Female sex is one, especially anterior. Anterior anal sphincter is compromised because too much sphincter has to be sacrificed, more than 50%. And primary sphincter repair has not been done. So those who are not doing it, you need to do it. Otherwise, don't touch a fistula, which is deeper. Now you have to understand the muscles. So you have the internal anal sphincter and you have the external anal sphincter. So what can we save? What can we compromise? Internal sphincter can be sacrificed. You won't have a problem. External sphincter can be sacrificed, but not more than 50%. What is the danger zone is the deep part of the external anal sphincter and the puborectalis. At no condition should they be sacrificed. So if you stick to the danger zone, you'll be okay. Now another problem with these abscess fistulas are they keep traveling up. They can go up to the retromediastinum and they can go up to the pubic symphysis, to the abdominal wall, both iliac fossa. They can go to the penis, and that's where the whole problem starts. And we think it's a great problem. It isn't. The problem is on the dentate line. That's where the whole pathology is. All surgeries, like Dr. Alan Parr has said, excise the central disease. You take care of the origin of that fistula, you can tackle everything else. So fistulectomy, primary sphincter repair, you have to take out the branches. It prevents recurrence. Ratto, who has got the best paper, says 93.2% success. Post-op incontinence is 12.4, and this is just post-defecation soiling. So the patient has to sit, wash, walk about, come back and sit and wash. And manometry doesn't show any significant changes. And abscess is if abscess is the initial presentation and you think it's not conducive to do a primary sphincter rod, you just put a seton in. So the art of balancing recurrence and incontinence when you're doing a fistulectomy, primary sphincter repair. This is a patient which was operated beautifully and fistulectomy, primary sphincter repair was done. 10 days later, the residents give me a frantic call and they say, "Sir, I think we need to do a colostomy." And I also, thought maybe. But when I put my finger in, the tone was pretty good. That's because what you see here, the puborectalis, and the deep part of the external anal sphincter were intact. So he did have continence. Only to liquids and flatus he was not able to hold, but solid stool the patient could hold. All we did was take to the OT, took out all this dead tissue and left it, and within a month everything healed up. And he had just incontinence to flatus and liquid stools, and he was on ropamide. And he said, I'll get it surgery done, but I'm okay right now. So after seeing this and saying okay, was because the primary sphincter repair was done properly. Even though the lower part shed off, the upper part was still intact because it was not touched. And this is a fistulectomy for people who said they don't do primary sphincter repair. It was wonderfully done, but primary sphincter repair was not done. This lady is an old lady, and look at the patulous anus. Had it been done, this would not have been seen. And recurrence after doing fistulectomy, not doing a proper job because everything was done, the internal opening was not taken out. As a result, the patient kept having it over and over again, and that is what you need to address. So management of complex fistulas, high failure rates lead to recurrence. Functional disability is incontinence. Options are 3, but we are going to talk about fistulectomy and primary sphincter repair. So why does recurrence in incontinence occur? Because this is the fistula tract, and you operated from outside. It was like 8-9 centimeters away, and you went up to the external sphincter, crossed it, but didn't go all the way to the internal opening and left that small portion. You thought, okay, I've done 90%, 10% se kya hota hai? But if you reverse it and you did only the inside part, the 10%, and left everything else by curating it, it would have healed. So you can't leave this, and this causes recurrence. In the second condition, you have a suprasphincteric fistula, and you operated and you did a great job cutting everything. So this leads to incontinence. More than 50% was cut. Incomplete or no primary sphincter repair was done. Wound breakdown. I just showed you wound breakdown. So risk factors: 1, not identifying the internal opening, high transsphincteric fistula, multiple fistula tracts, horseshoe fistula, anterior fistula in women, history of anal procedures done previously. So the latest patient I have has been operated. I'm not operated yet. Coming week, he's been operated 9 times. And the maximum I've done was one patient was operated 18 times. So you have to be very careful in these patients who have been operated before. And high transsphincteric fistulas which were treated to loose cetons. So systemic approach for those who have some degree of incontinence is don't go jump in and do a procedure. Bulking agents and training the pelvic floor with biofeedback is the first line of treatment. Sacral nerve stimulation has come to India, is going to start in CMC Vellore. I think it's going to be cheaper than everywhere else. Invasive is surgical sphincteroplasty, which is not that difficult if you know how to do a primary sphincter repair. And colostomy, don't do it. Don't do it. It's the last resort when everything else fails. So this is a complex fistula. It was a challenging case, 12 o'clock, 3 o'clock, and you can't cut the external sphincter at 2 places. So at 12 o'clock, it was excised and primary sphincter repair was done. At 3 o'clock, coring was done. So workup of fistula, clinical examination, Wexner incontinence score, and MRI. So this picture you should have, and you should fill it up before surgery. Once you have done this, you go for the Wexner score, which is a historical. It tells you the status of the sphincter before the surgery. It's a medical legal paper. If you have this in your file and it shows the patient already has some degree of incontinence, so if they have incontinence later, you can say we have already taken it and he had a pre-existing. MRI, this diagram has to be there. If it's not there, change your radiologist. So height of penetration of external anal sphincter matters when you're doing a fistulectomy. So you have this, you can do a fistulectomy, get away with it. You don't have to even repair because hardly any external sphincter is involved. You have this one, you can do again fistulectomy. You can repair the sphincters or even leave them alone. This one, you have to repair the sphincters no matter what. And this one, you see the external opening is at the same place. So you can't judge how high it goes by looking at the external opening. Similarly, the distance, look at both the pictures together, this one and this one. Similarly, here, this one, it doesn't matter how far you are, they're all opening and they're all low. So distance from anal canal is not the thing. So the procedures you already know. Approach, let's go. You've done. We have done all this, and decision for surgery is done. And you should know where your fistula is. And you should know that in males 50% posteriorly and 1/3 anteriorly, females 1/3 posteriorly and anteriorly. Don't do it. If you do it, you have to repair it. So fistulectomy, I'm going to skip. Complex fistulas. So this is a patient operated 3 times before. And the MRI said maybe the internal opening is at 5 o'clock, and it's done by the best person in India, not just Mumbai. And but it wasn't going there. Going up to 5 o'clock, it just ended there. But following it up further, it goes and opens at 12 o'clock. And if you take the whole thing out and do the primary sphincter repair, these patients are going to succeed. So just remain very close to the fistula tract. Don't waver away. Don't go too far. Don't take too much tissue. Just the fistula tract. Therefore, you have to have the methylene blue staining it. And that's where the internal opening is. And when the dye was pushed, nothing came from the internal opening. So you got to follow the fistula tract. Don't be worried about it. And as you take it out, and when you're at the internal opening, please at the internal opening take a little wider cut, because you want to include all the glands in the region. 1 o'clock before, 1 o'clock afterwards. And when you do a primary sphincter repair, use Vicryl for anal mucosa, internal anal sphincter. This is what is being done. It starts from the internal sphincter, mucosa, internal sphincter. And with Vicryl, you do it couple of stitches, and then you start doing the external sphincter. And this is PDS. Now, for external sphincter, you need PDS. You can't do Vicryl. And PDS 20, 10 are good. 30 will break. I mean, when you're tying it, it's going to break, and post-op, you may be scared it's going to break. So minimum 20, 10 if it's possible. Take it. The sutures are from inside out. And once you do it, I'll come to the end, and you can just inject this. So when you have a scrotal fistula, they are not very deep, but they are very scary, because one, urethra is there, so you need to catheterize the patient. Secondly, when external sphincter comes, they sort of dip in and go inside. And that's where you say, oh, let's just curate it and leave it alone. And third is, they may be very close to the urethra. In this patient, it was very close to the urethra. So fistulectomy was done on the first part, the second part, the middle part, fistulectomy. That means it was just laid open and curated. And the lower third was fistulectomy was done again. So remain very close to the fistula tract, take out completely, and again suturing with Vicryl when you're closing it, and then PDS from inside out. And remember, don't close the whole skin. Just leave the skin open, do a musculation. This is the musculation being done. At end of the procedure, you see it like this. And this is another case, and see how the healing occurs. Now, this is for people who are scared in doing anterior fistulas in women. And to guide them how to do it, I took stay sutures to tell you how to do it. So it's been taken out. This probe is put in. And I want to cut this muscle. That's the muscle I want to cut. So I will take stay sutures on both sides. This is for people who are learning. I don't use stay sutures. And then you cut. So in the end, you know which muscle you're going to be stitching. Take it out. And curate it well and take this. One thing I want to say, those people who have laser, how many people have laser? Use the bare fiber to cut the fistula when it's in the muscle. Outside, you can cut with cautery. It's very accurate. It doesn't cause blackening. It doesn't cause burn. And once you clean this, then you start doing the PDS closure. Take it on both sides. Take it. You can do a box stitch or you can take an individual stitch, but you have to close the sphincters. In the end, it would look like this. So, evaluation of a patient who has a recurrent fistula, detailed history you have to take. MRI, colonoscopy to rule out suspected IBD, biopsy if you suspect malignancy or tuberculosis. And if previous surgery is a sphincter saving one, I usually do sphincter saving in the first try and repeat sphincter saving, or you can do a fistulectomy with repair. Caution in recurrent fistulas, dividing sphincter multiple times increases incontinence. Post-op management is very important and you have to do it yourself. Don't give your technician to do it. Periodically assess the wound. Make sure the deeper parts heal first. What happens is the superficial part heals and then you have a collection because the deeper part hasn't healed. The key to management of complex fistula is the excision of the central disease, that is the anal gland, the mucosa. So take a 5 millimeter margin of the anal gland and mucosa, go up to external anal sphincter and you've taken out the disease. Everything else you can do by curate. That's it. Primary sphincter repair achieves this and add primary sphincter repair. If you want more training, I have a lot of students in the audience who have done IMAST. Thank you for coming and I hope your life has been successful. And if you are interested, you can take a picture of that. And this book is available outside. It's got 200 videos and everything I told you is in that book. Thank you so much.
Thank you so much, sir. Hello. Yeah. Sir, thank you so much. Sir, you are one of the first person in the India to start minimal access surgery, especially in the anorectal region. So how come you are proposing this? I mean,
because
the topic was given.
Ask Tarun. He gave me the topic.
Okay,
I would have wanted that, but what the boss says I have to do.
Sir, one more thing. Can all these procedures be done with minimal access also?
Most of them.
Great, sir. Thank you so much.
Okay.
Any question from the audience? Yeah, please.
Yeah, if MRI was done a few, say a month ago, and on the table we don't find an internal opening, so should we make?
Do not be alarmed. Number one, look at the MRI where the tract is going to. If it's going only up to the internal anal sphincter and not crossing it coming to anal canal, so that's where the internal opening is going to be. So we get scared कि उधर तक गया फिर where कहाँ चला गया. And rule of the thumb, most internal openings, 90% are at dentate line at 6 o'clock. About 7-8% are anteriorly. A very few percent laterally. So your internal opening is going to be dead sure at dentate line posteriorly. So if the probe goes to some distance, that's one. Secondly, you can cut around circularly around the fistula, cutting up to subcutaneous tissue, and with the LS give a tug. You will see it moving inside, or you can follow it, or give methylene blue inside and just follow the fistula tract from outside. You're going to get there because it's the whole problem starts there. There's no question of internal opening not being there. It just gets stenosed or closed. That's all. And that is a temporary phenomenon. If it gets active again, it will open up again. You said 1 month, so it can close.
So closure doesn't mean healing. It means that
No, closure doesn't mean healing. That's where we falter.
So what is your take on trapezoid mucosal flaps for anovaginal fistulas?
I don't use anovaginal
This is
fistulas.
hardly
If
any
they have been
dissection
done,
required and the thing.
if they have been done primarily, that means you are the first surgeon to do it. I'm not talking about gynecology. If you are the first surgeon and it's been like 3 months since this has happened, everything is matured. Do a primary repair, fistulectomy and primary repair. But if you feel like I get patients who have been operated 3 times, 4 times by surgeon, plastic surgeons, and all flaps have been done and it goes away, then I do a Marshall's flap, that is take the labia right or left and insert in their place because there's hardly any muscles. You repaired all the muscles and there's a gap between the muscle and the skin. So you just fill that labral fat pad there, is vascularized, and close it. That's it.
We've been doing trapezoid flaps and we've had good results with trapezoid flaps. And because the perineal body may be damaged during delivery in young ladies, so you don't end up, damaging them in any way when you use a trapezoid flap.
Yeah,
So I thought it has an advantage. So probably you would have.
Okay, I don't have it because I'm happy with the ones I'm doing. If I had a problem, maybe I would have gone further ahead. Any other question? People in the back are quite quiet. And I hope who are not doing primary sphincter repair. It's not a tough job. You are surgeons. You can open abdomen, left, right, center, and close it. And abdomen is a big thing to close. And this is just a small muscle to close. Yes, please ask.
What a
Yeah, it doesn't cause any problem because you are saying the fistula is extra sphincteric, but it's going up to the levator, right?
Yes, sir. Not extra. Let's say a very high
High,
transsphincteric.
see, you have to define high.
Right.
High means it could be intersphincteric high. That is
No,
between the sphincter
high
and going up.
transsphincteric, sir. High
High
transsphincteric.
transsphincteric. So high transsphincteric, you have to approach in two ways. From outside, you go all the way up to the where it's going, and from inside, you dissect. It's very easy. You have to know from inside. Give saline and adrenaline to that area very nicely. Cut out that section opening, internal opening. Hold it with LS and tell your assistant to lift the mucosa and the internal sphincter, and you just follow the track. It comes so easily because we don't think about it. We think it's a big thing. It's not a big thing. You can do it. You just follow the track. It will go up because it's fibrosed.
So this is a proper cutting fistulectomy, not a coring fistulectomy.
No, it's see, you can do cutting by cutting the whole thing. By cutting internal anal sphincter till anorectal ring, no problem.
Right.
It's not you cut the internal anal sphincter, it goes like this. External sphincter is outside, like Dr. Pradeep said. Internal sphincter is already fibrosed. Once you cut it, it's not going to go away. It's going to stay there.
And the external, sir?
External sphincter, you don't have to cut it. If it's high, if you cut it, you have to be really good. And if how to prevent injury to anorectal ring, whenever you're opening a fistula and doing a fistulectomy, your one finger has to be on the anorectal ring.
Sure.
So you know how far away it is. And if you're anywhere near it, don't cut it.
So for a very high transsphincteric,
You can go from outside as far as,
better.
yeah,
Sure.
and from inside.
So I have two questions. One, how do you really identify the intersphincteric space externally? And how do you identify the internal sphincter and the external sphincter during surgery?
Intersphincteric space is a beautiful space. You can find it by giving traction on it. So if you MIPH anoscope, which is there, if you put that inside, it becomes very tense. And if you take the back of a forceps, back end of a forceps, go to dentate line, press laterally and come down, at the intersphincteric space, it will dip. Very simple. It will dip. You know this is the space. Or you can put your finger and come down. So it's tense. Then it gives way because the external sphincter is coming. That's the intersphincteric space. The other question was?
How do you identify the internal sphincter and the external sphincter while surgery?
That's what I'm saying.
Right. No.
Internal sphincter is
Any
medial to
difference
that.
in color, in the position of in the direction of the muscle fibers?
Internal sphincter muscle is whitish. Color you can't tell because the moment blood comes, everything becomes one universal color. So color is not the thing. The muscle is. External sphincter, when you touch it, twitches. It's going to twitch. Just a cautery is going to twitch. And the tip I would like to say, those who have laser, use a bare fiber to cut when you're going through the muscle. It cuts each single fiber separately. And there's no soot or blackness behind. So you see the field very nicely. I think they're going to shoot me if I don't go. But you can ask me questions outside.
Yeah, thank you so much, sir. Thank you.